joined today by Izabela. So we've seen some comments on the Facebook group about going straight to LTPs, so we just want to address it and why we're doing it. So one of the things that's come up is, something about spare prosthetics. Have we ever had spare prosthetics, or have we had a deprogrammer and an LTP?
Right, okay, we didn't have a spare prosthetics. Deprogrammer specifically made for the purpose to deprogram old habits, to deprogram the way you're chewing straight after the surgery, when you kind of moved from the tooth reality, failing dentition reality, to the prosthetic reality. So that was the purpose. So they're not spare, they're not identical, they don't look the same, they don't have the same purpose, they don't have the same occlusion design, nor other sorts of things.
And also, now that we can go straight to LTP, and we'll talk about how rare that actually is, you can dial in the full occlusion from day one, can't you? So you can deprogram and boost adaptation immediately at the same time.
Yes, we can. There are some limitation with the deprogrammers if we're talking about the mechanics, right, which we need to respect. The deprogrammers, the first prosthetics that were placing using the traditional workflow, as I say, different mechanics rule apply to them because it's only polymer. Right, so polymers, they have some flexibility. Okay, so you need to actively work of precisely calculating functional and non-functional cantilevers. Yeah. So therefore, most of the cases, the patients were giving only 10 teeth on the lower jaw with reduced occlusion 3 to 3.
Yeah,
okay.
Just here at the front, right? Just
yes, in the
here
front.
At the front. Yeah.
That's why the patients sometimes ask me, "Oh, why do I have a small gaps on the back?" So the main advantage, if we're talking about occlusion with going straight to LTP, we can give them 12 teeth with a functional occlusion on all of the teeth from day one.
So we can deprogram and dial in long-term occlusal parameters immediately.
Yes.
Remind me again how many people in the world can do that with a bar pre-made to fit the implants that you know of? I mean, they might exist. I don't know of any.
According to my knowledge, none.
None. Right.
But
Okay.
But the world is a big village. Maybe there is somebody.
Yeah, that might be why no one else has got it on their website. Maybe.
Yeah, maybe.
Because we're just doing something that no one else has ever done before. And you've been doing it for a while. You're looking at the results.
Yes.
If you look back over your own career, looking at these results, you as the surgeon operating, how much safer do you feel for your patients using this?
Well, that's the next level. So I feel safer for the patient and I can sleep peacefully at night. So I really worried about something if it's not 100%. So for example, there are things that I cannot have control of. For example, a low bone density, right? Soft bone. Okay, so we have patients with soft bone. We have patients with limited bone volume when I can place only very, very short implants. Or in a soft bone, I don't achieve a great primary stability. So basically, we always measure the torque. When I place the implant, I always measure the torque, the force that I insert the implant with. So we work off numbers because we are scientists, right?
Yes.
So if the numbers
Not opinions, numbers.
Yeah, so if the numbers were low, I was a little bit unsure. I was like not feeling that I'm giving the best predictable outcome for the patient.
Yeah,
I was like crossing my fingers behind my back sometimes.
Yeah, but you had no choices, Izabela.
Yes, we have no choices. Or, for example, patient telling the patient, you must be on a liquid diet for 4 weeks, or you must eat a fork diet for so and so long, because I needed to respect the flaws of the PMMA prosthetics.
Yeah.
And I mean, in context of the surgical difficulties, anatomy difficulties. So right now, it's a game changer, right? It's just something like if I want to try to explain in a simple words, if you have a fractured leg and you put a bandage over it, you say, okay, you can walk, but you have to use, 2 crutches and never, ever, ever step on it, right? If you put a cast on the leg, it's far more better, far more predictable.
Yes.
So the same with the implants. So we're introducing the implants, so we introduce a trauma to the bone. Okay, and if I have a rigid cross-arch splinting
Rigid
with
cross-arch
rigid
splinting, not
cross-arch
cross-arch
splinting,
splinting
because
that
we
we
always
do.
have a cross-arch splinting,
Yes.
right? But rigid cross-arch splinting, I'm greatly increasing the best outcome, and I reduce possibility of early implant loss or lack of osseointegration.
Let's also talk about the fact that when they're going through the biggest adaptive phase, which is the first one. So I've talked about this many times, one design, one time, getting those parameters dialed in so the tongue and the lips adapt to things quicker and more comfortably, because everybody goes through swelling, and then when the swelling calms down, it just finds this new thing and they get used to it. How much of an advantage is it to not have 2 prosthetics?
Oh, Jesus, this is great advantage because you're going through the pain of adaptation once.
Yes.
You just find with the traditional our traditional approach when we give
which
the
is what
deprogrammer.
everyone else on earth does.
Yes.
But nowhere near our standard.
Yes.
So
yes.
they're still converting dentures, a lot of people, correct?
Exactly. Right. So the patient go through the pain of getting used to it once, and then they get confused few weeks later. In our case, whatever, 8 weeks later, to the new prosthetics, and they start biting the tongue again, and start biting the cheeks again, and they start a little bit having difficulties with the speech. So in the process of going straight for the LTP, it's happening only once.
Yes.
And as you said before, it was very interesting saying that, after the surgery, when everything is swollen, when everything is out of the place, we guided the muscles, we guided the soft tissue to adapt and to heal into it. Mm-hmm. We give them almost like a scaffold to heal into it. Mm-hmm. Okay, so I was very, very surprised when I was reviewing my first LTP cases, straight to the LTP cases. I was worrying about the gap, the space in between it. Okay, so I was like, oh my God, how it's gonna look like? And when I removed the prosthetics, only from my curiosity point of view,
yes,
okay,
I know,
only for my emotions, I wanted to see it, how it looks like. I wanna, see it and take photographs of it, take records of it. It looks like the body healed to the titanium fitting surface of the LTP, just perfect, just right. So the tissue were not overcompressed. There was not humongous space in between it. It was just right. It was just perfect.
From my point of view, from my experience, what I see is the tissue finds what it finds comfortable. We're not forcing it. It finds what it is comfortable with. I think people forget that. So if I scan everybody's mouth every single day, and I take a picture of the papilla between their teeth, I can guarantee you over 2 weeks, it changes.
Of course it changes.
Yeah, but everybody seems to think that the gum never moves.
It changes depending on
it's permanent. It's a living, remodeling tissue.
It fluctuates.
But it's now living and remodeling against something that just doesn't move from day one.
And is highly, highly biocompatible.
Highly.
Okay, so it's not porous. Titanium is a biocompatible material. Okay, we've discovered in 60s
your
or before.
Your implants are made out of titanium.
Yeah, exactly.
So my bar is made out of titanium.
So this is the best material you can have it against living tissue.
And in terms of fracture risk affecting implant stability, with the splinting of the bar immediately, are you worried about fracture risk?
No. No.
Is this the first time in your career you've never not been worried about fracture risk?
No, I've never worried. I never worried about shoulders blowout, about fracture risk of the bar. I'm not. I'm kind of very comfortable that the implants are safe.
Implants are safe?
Yes, the implants are safe.
I knew there was a reason that I was trying to get a bar to fit. It's about implant safety. Let's call it for what it's for. It's implant safety, right?
Yes.
Right. Okay.
Okay.
So have we managed to secure implant safety
Yes.
by going straight
yes.
to LTP?
And you know what? My patients, they're just humans, right? And you tell them it's fork diet, it's soft food. And guess what some people are doing, especially men?
Steak.
Yeah, they go
Obviously.
next week and they have a steak or they bite on a burger. And it's
what,
like
you mean some of our patients lie to us, Izabela?
Yes,
Oh
I'm afraid
my
so.
God, that's
yeah, and then I see it on the Facebook photo 7 days after the surgery,
at a
biting on a
steakhouse.
burger.
Yeah, biting on a burger, stuff like that. Yeah.
So you know what? When the implants are rigidly cross us splintered, I'm so like, okay, you are bad man. You did not behave, but okay, you're forgiven because the implants are safe.
Well, correct me if I'm wrong, but Professor Branimar, who gave us modern implantology, has always stressed the importance of rigid cross-arch splinting. And if he was still alive today, how much would he like the fact that we can introduce the bar from day one?
I think he would be very, very jealous that he's not living
Very
right
jealous.
now. Yeah, he'll be living
He'd be
that
jealous that he's not living today.
Right, yeah.
Yeah, but he didn't have the technology in 1962.
That's what I'm saying. That's why he'll
Cut
be
the man a
jealous.
break.
Okay, so this is, as I said, is the holy grail. Okay, of all the implantologists to give as best environment for the implants to heal, because the implants are anchorage for your prosthetics, for your functional smile and stuff. So yeah, the technology allows us to do it today, and I'm very grateful for it.
I was reading a comment from a patient who very detailedly laid out that because she's getting one less prosthetic, I should charge less. Okay, well, I just want to reply to that by saying I spent £2 million and 2 years of my life to develop something that I know is better for everybody, and I could only do it today because the technology is available today. And people are grossly underestimating the amount of work we do away from the chair so that we can do this in the chair. Are we shortchanging anybody by not giving them a deprogrammer? Or if it was you, would you prefer straight to LTP, or do you want to wear a deprogrammer?
No, I want to work straight to the LTP.
Okay.
I mean, I'm hoping I would not need it, but if it would be my dad, I would like him to go straight to LTP. I actually did a correction for my father-in-law and my mother-in-law, and I wish they would go straight to the LTP, especially because they are still living in Poland and they have to do the trips to England. So dental tourism they did to come to. I would feel much more secure when they were back in Poland if they would be straight for an LTP.
So all these patients who routinely do this, so they come and have surgery with us, and then 5 days later they're on a plane to Tenerife for 2 weeks. Is it better that they go straight to LTP rather than going there with deprogrammers?
I'll put it this way, I will not have any phone calls on a crazy time at night or on a weekend saying, oh, I think my prosthetic is loose or something.
Or broken.
Or broken, yeah.
Okay. So do you see any disadvantages to going straight to LTP, really?
Yes, for me.
For you?
Yes.
Why?
Because I need to take extra steps in planning and in a surgical procedure.
Okay, but are those extra steps in planning and surgical procedure for your peace of mind and your patient safety?
Yeah, I just wanted to find a reason. So I just said it.
Right, okay, you were just fishing for something.
Yeah.
And then the other thing that somebody said, which was really interesting, I found was, well, what if I pick the wrong color? So I was going to take my car back to the garage after driving it for 3 weeks and tell them I picked the wrong color, just to see what they'd say to me. I find this whole concept of this test driving nonsense. Make a decision. Make a decision, stick to a decision. B1, A1, and A2 isn't the difference between black, white, and orange.
No, it's not.
Right, it's not that wide a gap. It's just 3 colors. And any of them are better than the start point that you've seen on any patient, am I right?
Yes.
So everything's relative and everything's in context.
Yeah.
But we are about the health, and from a health and stable function point of view, is there any doubt in your mind that the ability to grow to straight to LTP, and as far as you're aware, we're the only people you've come across on Earth that can have a pre-milled metal interface, metal reinforced prosthesis fitted immediately after surgery.
Yeah, that's correct.
Right.
Mhm.
And if everybody had access to the technology, would everybody do it?
Yeah, they would. 100% they
Who would do a temporary ever again?
No.
Who would do it ever again if they could just go straight to LTP? So I've heard this nonsense. So some patients who've rung up recently have said that other people who don't and can't do what we do told them that it's dangerous to do so.
No, it's
Now,
not
I feel
dangerous.
sorry for the patients because they don't know. So I just want to hear from you about this danger thing. Is it dangerous?
I can't
Or is it safer?
I can't imagine in how come it could be more dangerous. I just can't think about one reason.
No, neither can I. There isn't one. That's why I invented
Oh,
it.
that's why.
I
Okay.
invented it because it makes it much safer. You know what I mean? I don't see any downsides at all. So for me, I just wanted to clear that up, and I wanted to get your input on it because I understand it from the patient's point of view. They do a lot of homework. They look around everywhere. We just do things that we calculate, and we've got the kind of investment behind us that allows us to be able to do these things. It's what we do. We spend night and day looking at this stuff and trying
Yeah.
to improve it for the patient.
Yeah.
The simplicity of being able to do a clinical assessment on someone, plan everything to the nth degree with very high quality data from the beginning, take them to a one-time surgical intervention,
Yeah.
fit them with the LTP, give the body the time it needs to do whatever it needs to do with, like you said, the rigid cast on the broken leg, so everything's kept nice and
Yeah.
stable while it heals, and then to be able to look them in the face 12 weeks later and go, everything's fine, go away. That's the holy grail, and we can do it.
Yeah.
And I know this. I know that everyone will go in that direction soon.
Yes, they will.
Temporaries will be a thing of the past. Deprogrammers will be a thing of the past. But I had to wait for technology, and the technology's here to be able to do this. But it's inevitable that it looks like the future.
Yeah, it does. I mean, it's just absolutely nonsense to kind of keep doing the same stuff. What we used to do it. Do you remember what we used to do it 12, 13 years ago? Denture
Very
conversion.
well. I was there.
Yeah, exactly. Converting actually plates denture by drilling holes in them
And then gluing metal cylinders.
Yeah, putting metal cylinders, so sticking some chairside material, and then hoping everything's going to be fine. We
And
can't keep continuing this in 2020. Yeah,
But
25.
again, for me, it's the patient safety. The patient safety and the consistency of it, and the security for both the patient and the operating clinician, knowing that we have absolutely minimized surgical risk at that point, because it's the one thing we never want to do. We never want to surgically intervene on a human being twice.
Yeah,
We never ever want to do that. They don't want it, we don't want it, so you've got to engineer in every single fail-safe you can find.
yeah,
Now, luckily, we live in an age where I have access to the kind of technology that'll allow me to sit around and work these kinds of things out, and then you can deploy them and you see the results for yourself.
yeah,
And for the people who had deprogrammers with us before, I just didn't have the technology.
yeah.
But for the people moving forward, and straight to LTP, does it allow us to help a lot more people than we could before?
Actually, yes, because we're going to have more chairside time.
Yes.
We are reducing one long appointment, which is data capture, okay, which takes around an hour, sometimes a little bit longer. And at point, it might be a little bit unpleasant because taking the prosthetic on and off, which basically going to the, gum level, it can be a little bit unpleasant at times, okay? So if you can avoid it, why not?
Absolutely. And we know this principle that every implantologist on earth accepts, which is one abutment, one time.
Yeah,
And this principle is about not disconnecting anything from the implant interface ever once you fit it down, correct?
Mm-hmm.
Right. So I don't understand why it's difficult for people to understand that we are working to one bar, one time approach.
Mm-hmm.
This is, for me, so important at the biological level for the long-term stability. And why do you ever need to take these off?
To be honest with you, if there is no clinical or radiological reason,
Right. So no bleeding, no pus, no active disease at all.
no bone loss on the X-ray.
No bone loss. Do you ever recommend scaling around them with a scaler tip?
No.
Do you ever recommend poking around them to check what's going on?
No, we have other tools to keep them clean. So
well,
when
radiology
the patient,
for starters.
Yeah, when the patients are coming for the annual maintenance, we are using the airflow with a glycine powder, with a specially designed powder to clean the bridge underneath and the interfaces with the implants without any damage to the soft tissues or to the metal highly polished surface.
Yeah.
So there is no reason. Have a look. No, it's no reason.
So the days when we need to visualize by taking things off are gone, correct? So actually, other than a requirement to service a broken veneer, right? How many broken bars have you seen?
No, I haven't seen any broken bars.
That's what I thought.
I mean, I used to see them ages ago when there used to be cemented cylinders in the bar, but we're talking 10 years plus ago.
How many milled bars have you seen break? None. Right, that's what I thought.
You literally can drive a car over them.
You can drive a car over them. So we know they're that solid, right?
Yeah.
And then we've got the veneer on top, which we actually put in as a fail-safe because we know something. We know that patients with implants have no nerve supply at tooth level.
Yeah.
So they can actually bite much harder than if they had their own teeth.
Yeah.
And because they have no proprioception, they will break stuff.
Yes, they do not realize how hard they're biting. If they chip a tooth or break a prosthetics, they usually, I was biting on a soft, cake or mashed potatoes, and they break because, as I said, they don't realize how hard are they putting the teeth together.
No, they don't, because they never can. Because there's no feeling in prosthetics. There are no nerve supplies in prosthetics. But how straightforward is it to service that if ever you needed to?
Yeah.
Easy, right? And the mindset of temporaries, spares, this is all old world now. Definitely for us. Because considering that we're doing 150 to 200 jaws every single month, the security that it gives to all our clinicians who are doing this without the need for switching from deprogrammer to LTP and just moving into analytics only and making sure bone health and tissue health are correct and just concentrating on the health parameters. Are they disease-free? Are they functionally stable? Is the mouth pretty much taking care of itself? Does straight to LTP tick all your boxes for you?
Yeah, it does. It does.
Right. Good. Thanks for that. So just to recap, straight to LTP is very much a thing that we're using more and more and more in this company. It is really important from a longevity and stability point of view. This is not, I'm going to reiterate again, 21D is not a cosmetic service. We are about health and well-being and longevity. The only way to measure the success of this, I'm assuming, is if you see the patient 25 years from now and everything's as you left it.
Yeah.
There's no other measure of...
Yeah, we'll leave it to our kids.
Leave it to our kids. Okay.